next we can trigger topics, cognitive behavioral features of both KAT6A and KAT6B.
Hi everybody, welcome. What's novel? KAT6A, KAT6B disorders, and some of the research we've been doing recently. So first we'll review the known characteristics. We'll summarize the cognitive growth, and we'll update our research study. So these are the clinical features of KAT6A syndrome that we know about. So we see lots of system anomalies, eye findings, GI findings, craniosynostosis, heart defects, growth abnormalities are all really common things. But by far the most common features of KAT6A syndrome and the universal features are neurodevelopmental, neurobehavioral findings. So 100% of patients have either a diagnosis of global developmental delay if they're very young or intellectual disability. More than 3/4 are rated as having abnormal muscle tone. It's probably even a little bit greater than that because some studies don't report on the hypotonia. And behavioral problems are common, but a lot less common than the cognitive problems. And seizures, you don't know the actual prevalence, but it's not an incredibly common finding, but more common than in the general population. KAT6B. On the other hand, two clinical categories of KAT6B syndrome, but we also now know that there are a number of people with pathogenic KAT6B variants who fall outside of these two categories. They also have a great number of organ system anomalies or growth or structural anomalies, a little bit different between the two different conditions, the FBD-YSS and the genital controller syndrome, but with a lot of overlap. And we know that neurodevelopmental findings are also very common in this disorder, although that is a little bit less characterized in the existing. So how do we manage the neurodevelopmental and neurobehavioral problems in KAT6A or KAT6B syndrome? So we recommend early intervention, developmental therapies, PT, OT, speech, definitely educational support once those kids start school. And we know that communication is a big issue for both of these disorders. And so all types of communication, whether it's sign language or assistive technology or verbal speaking, all should be used to maximize communication in these things. We recommend an echocardiogram, regular eye exams, treatment of GI manifestations, sleep study if there's sleep apnea, and abdominal ultrasound to look for any abdominal congenital anomalies that we may see. And we say consider brain MRI if there are concerns like a focal neurologic exam or seizures, but we don't commonly recommend routine brain MRI on everybody with KAT6A or KAT6B because it needs to be sedated and we often don't find something that useful. And definitely an audiology evaluation should be done because that's the standard for any kid who isn't speaking the language. And so now we can review a little bit about what's known more specifically about the neurodevelopmental and behavioral characteristics. So from a brain malformations perspective, in KAT6A, there are many minor brain malformations reported. We call these non-specific findings. So they're definitely abnormal compared to the general population, but they aren't something very specific or diagnostic and not really something that is actionable. In about 1/3 of cases, there is microcephaly or a small head, and often we see corpus callosum abnormalities. But again, almost all of these don't do anything. KAT6B, the majority are actually reported to have agenesis of the corpus callosum, and half have a small head size. But again, neither of these are actionable findings, which is why we don't routinely recommend it right now. Hypertonia is low muscle tone, so that's your loosey-goosey kind of floppy kid. And this is reported in the majority of patients with both KAT6A and KAT6B. This comes from the brain, so this doesn't come from the muscle. There's nothing wrong with the muscle. Of people with KAT6A and KAT6B, it's a signal that the brain sends to the muscle that is abnormal. It's very significant in infancy, but it still is present in later life, although many kids walk. And physical therapy is the only known treatment to help with hypotonia at this time. Seizures, again, like you said, more common than in the general population, but still not a common feature of either condition. So it's not the majority of either condition that has seizures. But when there are seizures, multiple different types of seizures have been reported for both. And because this is an uncommon complication of two very rare syndromes, there aren't any consistent recommendations about what seizure medicine should be used or should not be used. We just really don't know that information yet. Neurodevelopmental issues are generally the primary concern of families. And this is where our research and clinical care is mostly focused at Krieger. So early development, the developmental milestones are generally universally delayed. So that is everything: growth motor, fine motor, social, emotional, and language. Growth motor, usually has some catch up from early infancy, but they still are going to be not as coordinated or athletic as many of their peers. Fine motor stays pretty steadily behind throughout life, and language and cognition we'll discuss a little bit later. Children can often look a little bit more delayed in early childhood, and as we're able to measure more, they're able to show us more things that they could do, and the scores can get a little bit better. And early engagement with therapies through infants and toddlers or other mechanisms is very important. Behaviorally, about half or a little bit more individuals with KAT6A and KAT6B syndrome have reported behavioral issues. This can include autism, ADHD, sensory processing issues, and you should treat those the way you would treat these behavioral issues in any kid with a neurodevelopmental disability. We again don't have the data to support specific treatments or management plans for KAT6A or KAT6B as opposed to other neurodevelopmental conditions. But again, we know that behavioral issues in these conditions are an issue. It is something that families deal with, but honestly it's a lot less frequent than some other neurodevelopmental or intellectual disability genetics. Okay, so now we're going to move on to talk a little bit more about the work we've done in the neurocognitive phenotype of KAT6A. For KAT6A syndrome, neurobehavioral phenotype of both KAT6A and B disorders are relatively narrow, but both KAT6B or KAT6A have a way more research. KAT6A we know is associated with global developmental delay. When we look at sort of retrospective studies, meaning that we look at medical charge studies, we tend to see improvement over time with the motor domain better or earlier, more so than language domain, where the disease tends to plateau earlier on. We know that in other studies, again, looking at medical chart reviews, that developmental patterns seem to differ by physicians with variants. So in a study with about 76 patients, when we review a clinical phenotypes in these individuals and early developmental milestones, those with the late Arcadian variant tends to show most significant delays in early development than the
than early truncating variants. Among the KAT6A, obviously we got intellectual disabilities nearly universal, but now with a kind of more systemic kind of growing forward, we do see a small subgroup who are having more kind of preserved cognition. But that being said, language skills seems to be affected in those that subgroup particularly. Most individuals with KAT6A have IQ in the moderate to severe range. And our further observations of developmental delay, we also see that the late truncating variant seems to be associated with more significant intellectual disability based on current reported truncated adaptive skills, so the kind of life skills. Albeit like intellectual disabilities again were based on that review rather than performance-based measures. And it's important that again, like with KAT6A and KAT6B disorders, intellectual disability is not always a good kind of capture of the cognitive profile because this high discrepancy with verbal skills being more affected, and so your nonverbal skills seemingly to be a little bit better observed based on parents' And in KAT6A, we know that about 70% of affected individuals are minimally verbal, so meaning that they are either not using the speech or having very minimal speech. And there seems to be kind of emerging research suggesting that there might be kind of discrepancies between receptive and expressive language development, with receptive or meaning language comprehension being better than expressive language. But other more recent studies with informant reports on day-to-day life seem to suggest that the sort of development are pretty similar. We know late truncating variants is also associated with more difficulties or greater delays in language comprehension, but there seems to be less of a difference with expressive communication based on the truncating variant. And then KAT6A is also significant, again, this is easily associated with oral motor reading challenges, and we do see again, late truncating variants seem to be having more greater reading difficulties than those with early truncating variants as well. But again, all of these are often based on sort of a medical chart review rather than kind of prospective or kind of data or data. With regards to KAT6B disorders, there is fairly limited literature with like essentially only kind of case studies documenting that speech language seems to be affected in this population, which again overlaps with what we know with KAT6A disorders too. I'll show you from one of our more recent studies that we published. We do we are seeing very similar kind of patterns with the KAT6A disorders. But generally, when we see that again, like the most common kind of case report clinical features finding from a cognition standpoint is that again, language and speech is typically pretty affected, and there's a high proportion of mainly verbal children with speech disorders as well. Among the disorders, there are some case reports with like medical chart reviews that intellectual disabilities seem to be more affected in those with genetic pattern or the subtype than the diversity. And again, there also seems to be some behavioral features, including that associated with like autism features, anxiety, and sometimes attention difficulties. But again, these still tend to be relatively lower rates compared to other individuals with similar level of cognitive functioning without genetic conditions. So overall, the takeaway is that again, there seems to be evidence of chronic challenges in language and speech in both KAT6A and KAT6B disorders, but we need to know more about how much of this are dependent in the diagnosis. Late truncating variants can be associated with more cognitive challenges in KAT6A syndrome, and there seems to be some emergent patterns from our earlier publications that this might be emergent in kind of visual motor skills as well. There is high kind of variability in the phenotypic presentation of KAT6A disorders, as we think of it as spectrum-based disorders as well. And there are also emerging kind of preclinical studies that are now suggesting that there may be posing a rescue of cognitive machines with animal models of evidence of cognitive disorders of evidence like KAT6A. But again, we need more research to better understand sort of the phenotypes associated with this disorder, which can also inform sort of what our treatment markers, what are things that we really want to look for if we have a clinical trial. And just certainly what we have more recently published in the past year with regards to sort of the comparisons between KAT6A and KAT6B. generally we're seeing very similar phenotypes across both and similar levels of cognitive functioning. So there was no really significant difference at a group level because of KAT6A cohort and KAT6B cohort across sort of like visual motor, visual processing, nonverbal reasoning, and kind of language comprehension measures. But we do see in KAT6B disorders so that's much higher variability in scores. So represented basically that there's just a more kind of a spread of different scores in the KAT6B disorders than KAT6A, where it's more of a cluster. So issues that we've seen in our more recent study is that about 25% of our KAT6A cohort with KAT6A disorders could not actually go on our cognitive measures, so they were not able to generate a kind of standard score to begin with. And this was all in about 33 or a third of those with KAT6B disorder. And so when we had those with KAT6A disorders who were not able to kind of go on our cognitive measures, reflective of that their cognitive skill level were below sort of what our tests were capturing. Most of those were again like represented by late truncating variants. So I was again suggested that late truncating variants were but when based on our initial study, we were well, and very kind of our then was to think about sabermetrically. So thinking about methodologically, not only do we need to know about sort of the cognitive pattern or profile of both KAT6A and B disorders, but then we really need to make sure that we have appropriate measurements. So we're thinking about what are measures that we can kind of capture this big spread of scores, especially if we're thinking about what are things that we can use for measurement for a future sort of treatment trial. So with that, we had two studies that we ran the past year. Study 1 and study 2. One was our sort of school age cohort, thinking about those around 15 and above. And then our study 2 was looking at younger children, so those were 5 and younger. Our first study was really to kind of reshape our kind of test battery to think about what are measures that would capture this wide variability of scores in sort of in children with KAT6A and B disorders. And also thinking about if that those kind of cognitive performance-based measures are also reflective of what we call ecological ability, meaning that are represented or similar to what parents are observing in day-to-day life. And our study 2 was then looking at early developmental patterns in children with KAT6A and B disorders, and seeing that whether or not they show similar sort of patterns as our displayed. So we're testing in 2 ways. We'll also look at developmental progress. We have this idea if there are certain domains that are plateauing or are developing forward. So we had 16 participants, 14 who were completing complete cognitive testing, 2 additional who did remote studies for international families. They're age 7 to 15, with about on average about 11 years old. Most were tested at our last conference, and a majority of them have actually been completed. And then the first battery we're seeing this time, most of our participants were able to complete our current test for non-verbal cognition and attention. So the red bar is possible again, all of them are goals, and that's a big percent sort of spread of scores that we're seeing. And generally we have like out of like the 14 people or 14 individuals who completed our non-verbal IQ measure, all 14 were able to be on our measure. There was no effect, meaning that no one received the lowest possible score, which is good because it tells us that everyone must be able to be captured on the measure. Out of our 13 individuals who did our PPBT, which is basically a receptive language measure or language comprehension measure, 12 of 13 people measured or able to complete that task, and one was again based on standard score. But one person was again also late tricky. And 8 of 13 were able to complete an expressive verbal kind of communication. And so we look at expressive vocabulary for PBT. That looks like particularly expressive vocabulary. So if anyone can provide close enough word observations, verbal words, and words and functional communications. Again, 4 of the 5 participants who scored measures across all of these were in complete truncating variants abundant. So on the expressive language measures, of the 5 who received the lowest possible score, so those that out of the 5 completed, 1 was able to complete item skills. So again, we're able to get, again, this is sort of different on how we think about measurements, but oftentimes in our cognitive testing, we think about standard scores with normal reference for how we're comparing your children compared to a large cohort of individuals their age. But now we know that sometimes that we think about how we can also reconsider kind of statistically how our measuring changes. So another way of looking at it is that we can do raw scores. So rather than comparing them compared to other children at the same age is that they're able to do any of those items. And we were able to see that for most of these children, they were able to be able at least to run the artist measures, which tells us that they're not, it's that even if they're not getting the lowest standard score, they're actually being able to be measured on these measures to begin with. And then we still want to see this effect with these sort of visual processing and visual motor measures as well. We see greater sort of like flooring effect in when we look at standard scores, but when we look at raw scores, actually no one receives raw scores. So meaning again, no one received a score of 0. There's like of all our participants, everyone was able to do some parts of this test. And so, like another way that we can think about this is that basically, like whether or not we might want to consider using raw scores as kind of more nuanced measurements of change, rather than using a standard score relative to other when compared to other children without sort of measure. In our developmental studies, when we looked at sort of more day-to-day life for what parents were reporting, we had new updated sort of questionnaires to capture sort of like adaptive skills and developmental kind of estimates, and we similarly see that both our questionnaires, parents report, none are really clearing as well. So again, we can see wider variability, like again, red bar being the lowest possible score we can get. These scores were well up, again, showing that like, our parents are able to use these measures to capture the whole kind of work of different kind of patterns of study. And so again, these two questionnaires, we were able to kind of see that they were able to capture kind of all of the children taken. And our second study with our kind of 5 and under kids, so we had about 2-year-olds up to about 5 months participants. The mean age being about 3 years old, which about half of our cohort was had KAT6A and half disorders, and then what we are similarly seeing is that from the second measurement standpoint, no one received a raw score of 0 on our main years of mental measures. So suggesting that there are potential clinical utility in this kind of test pattern, capturing this wide range of function in early children with KAT6A and KAT6B. And what's important is that when we looked at sort of like their parent ratings of early cognition, and also our performance-based measures, so how the child actually performed on the cognitive measure, we see a significant strong effect. So we see about like we see basically about 85% of these kind of performance variability was captured by sort of their test score. Again, this shows that that our actual performance-based measures is also reflective of what parents are reporting in day-to-day life, sort of early emerging cognitive skills for their children. We do like young children under 5 already start seeing this kind of discrepancy between the receptive and expressive communication skills based on performance-based measures, so based on actual testing, but it's kind of in the more minds. When we look at this in a school age cohort, it's much more significant. So it might also tell us that, again, when you think about sort of development over time, receptive and expressive language in these children may be just developing as well. So it suggests that we also need to kind of continue measuring those two along the way as children and sort of so future progressions is, again, we need much larger samples to kind of get in our when we were interested to look at some sort of kind of sort of positions of variance. So thinking about early versus late truncating variants versus distance variants. We have our current cohort is really largely represented by late truncating variants rather than early truncating variants. We need more kind of broad kind of epigenetic syndrome studies for us to really understand what are sort of the epigenetic mechanisms and how they will contribute to sort of those specific cognitive profiles. Because again, other individuals with intellectual disability and some other epigenetic disorders may present with more nonverbal deficits and more preserved language functions instead. So we don't know why there's sort of like these kind of differences in how we're studying cognitive patterns. And then we also need to cross-measure neuroscience studies to really look at cognition with other epigenetic biomarkers. Looking for us to really think about what sort of factors contribute to these variability in functioning. For example, late versus early, the sense of and so, but here are some when we collapse our sort of first with our last 2020 study data, we are starting to see some kind of emergent kind of patterns or differences in sort of early versus late truncating kind of performance. But again, early truncating variants being like a little bit more preserved cognitive functioning compared to late truncating variant. But again, this is early truncating samples and kind of sample size of 3. So like we need a lot more robust sample in order for us to really make more predictions. And we just want to thank again the Foundation for supporting our pilot studies for years, like years here at Penn Krieger, and then and also our research team for helping us with test and all our families who participated in pilot.
Okay, any time for a few questions? Anyone has questions?
Asking the question, get close to the mic.
I just want to ask you, go back to the public solution. And use better one. On the KAT6A, do you have any number of the prevalence and the KAT6B? And also, is there any correlation between those findings and actual symptoms or presentation?
Yeah, so for corpus callosum abnormalities in KAT6A, it seems to be about a third, but it's really important to note that not everyone has had a brain MRI, and so we don't totally know the actual prevalence because that would require systematically making sure everyone had a brain MRI. And there's no correlation with function, so we think the two things are, we think that, KAT6A syndrome is causing these corpus callosum problems, or all of the brain problems, the structural brain problems we see, and it's causing all of the cognitive and behavioral, but the two are not related to each other. They're both just caused by the underlying KAT6A. And we think that the cognitive problems in KAT6A is on a molecular basis, meaning what is happening inside the neurons out to the broader neural networks like synapses and circuitry and things like that, and not reflected in the brain function, which is what we see in the majority of these types of syndromes. We believe there isn't any correlation. We believe we can gather nothing from these random little things on the brain MRI, that they are not well correlated with function, because again, what's happening inside the neurons is much more
Okay.
Thank you. I have a question about sleep and its role on learning and development. I'm wondering if you're studying the patterns of sleep behaviors in the intellectual and developmental health of the children you're studying.
Yeah, so we published a study 4 years ago, maybe, on sleep and KAT6A syndrome, and it showed that actually more than 70% of kids with KAT6A had some sort of sleep disorder. It wasn't always the kind of sort of hard sleep disorders that you pick up on a sleep study, so it might not always be sleep apnea and things like that, but it can be things that are still causing disordered sleep, like very restless sleeping, frequent night wakings, taking 2 hours to fall asleep, those kinds of things. And we know that sleep is highly correlated with development, and the numbers are too small to say that this specific sleep thing versus this specific sleep thing. All we can say is that the majority of kids have disordered sleep. But we do think it's a very, very important aspect of development. And for that one, as opposed to the structural brain MRI, we can't be sure that there isn't a causative relationship there. So could it be that KAT6A is disrupting sleep, and that is further disrupting your cognitive profile? Absolutely. Is sleep the entire explanation for intellectual disability? Of course not, right? But is it contributory? Absolutely. And the main reason are asking for, again, too small to really make cognitive signals. But the main signal that we saw is there is a correlation between sleep and some of the dysregulated behaviors that may be occurring during the day.
Okay. Okay, thanks. That's great. Our next presentation will be by Dr. Marco Biasi, and Austin Joubert. They're